Good morning. Welcome. Good to see folks and welcome back. We are kind of resuming our post-holiday grand rounds. We've got an active calendar coming up, including a whole series on age-friendly healthcare. And we have Dr. McGinn and Dr. Reynolds and Dr. Sagar and Tom. I think I'll just turn it directly over to you and we'll start.
Great. Thanks, Gary, and welcome everybody. This is always a fascinating topic for me, non-alcoholic, liver disease. And I think, we have to stay on top of this topic because it's evolving constantly. And we really need to understand where and how to refer and to think about this disorder as it moves up in the etiology of cirrhosis. It's really become front and center. So I'm excited. I'm also excited. Our speaker today is Justin Reynolds, who I've had the opportunity to speak with, over the few years I've been here. We're really lucky to have a national thought leader like Justin, on our team. Justin is an internist. He's a gastroenterologist. He's a transplant hepatologist. He's based at St. Joe's. He went to med school at UMich. And then I believe from there he went on to Stanford University to do his internal medicine residency, UCLA to do GI and transplant hepatology. And he's worked very closely with us on many different issues, including Hep C, NAFLD, and just great to have him here. Justin, thank you for joining us and updating us on this condition.
First, well, thank you for the invitation, and hopefully I'm sharing my screen and you all can see it. But no, thank you for the invitation. I'm excited to talk about this and this topic of steatotic liver disease or non-alcoholic fatty liver disease. As you alluded to, this is sort of a, this epidemic that we in the liver community are certainly dealing with, but I think really our entire medical community is dealing with in some way, shape, or fashion. So I am going to try to go through a pretty extensive presentation here. I mean, hepatologists, we could spend an entire weekend on this sole topic. We've got 45 minutes here, so I will hopefully distill down some of the highlights of what I'd like to cover for you. Specifically, I'd really like to go through some of the changes we've had in what we are referring to now as steatotic liver disease as opposed to fatty liver disease. And there have been some nomenclature changes that we will go through just so we're all speaking the same language, so we all know the same acronyms. I definitely want to talk about the prevalence rates of MASLD, or what we previously called NAFLD, and talk about this burden of disease that we're seeing because it has not only been growing, but it's projected to continue growing in decades to come. I definitely want to talk about how we can risk stratify and assess patients who have this, because that is critical for us to not only identify these patients when we're seeing them in our clinical practice, but that will help us to link them on to care and more aggressive interventions in their medical care. And then finally, we'll talk a little bit about treatment options at the end. There are some new options available for these patients, and there are many more options that are likely going to be coming in the next few years. So just to start, we'll set the stage. What is steatotic liver disease and who is at risk for it? So this term is a new term, and I'm sure most people here are familiar with the terminology of fatty liver disease, NAFLD, non-alcoholic fatty liver disease, NASH, or non-alcoholic steatohepatitis. And several years ago, there was an effort that was made to essentially sort of rename or reterm this disease. And this was in part because the term fatty liver was felt to be sort of stigmatizing to many patients, but it was also felt to not be a very accurate representation or a very accurate term to describe what we now know as being a very, metabolically dysfunctional disease, if you will. And when we referred to simple fatty liver, that really didn't encompass all the different elements of it. So several years ago, there was an initial iteration where it was referred to as MASLD, or metabolic associated fatty liver disease. But that really didn't get around the issue of stigma, and it really omitted the role of alcohol and the role that alcohol can play in some of these patients. So in 2023, there was a large meeting of many different stakeholders in the liver community, gastroenterology communities, even endocrinological communities, where essentially this new terminology was developed. And what we now refer to as steatotic liver disease is what we previously referred to colloquially as fatty liver disease. And what steatotic liver disease is it's basically an umbrella term. It is an umbrella that encompasses several different forms or buckets of steatotic liver disease, if you will. But obviously, we're going to spend the next 40 minutes or so really focusing on this first column here of metabolic dysfunction-associated steatotic liver disease, or MASLD, which we previously called NAFLD, and then a subgroup of MASLD, which is metabolic dysfunction-associated steatohepatitis, or MASH, what we previously referred to as NASH. Now, within this new terminology, part of the idea with this was to really focus on the role that metabolic dysfunction plays in this specific patient population. We know that patients who consume excessive amounts of alcohol can have fat within their liver, but they may not have other metabolic dysfunction associated, metabolic dysfunction associated with that. There's also patients who have a combination of both. They have metabolic dysfunction, but they also consume alcohol more heavily. And so this nomenclature really gives us the ability to more accurately subcategorize all of these different patients, whether they have a combination of MASLD plus alcohol, which we now refer to as MASLD, whether they more specifically just have alcohol-related liver disease, or ALD, or whether they have a more rare or less common cause of steatosis, whether it be drug-induced, genetic-related, or cryptogenic causes. So when we are trying to identify these patients who have steatosis on imaging, but we really want to know, is this MASLD, is it metabolic dysfunction-associated steatosis? One of the most important things to do is to really look at cardiometabolic risk factors. And what our guidelines are now suggesting is that if we have patients who we've identified as having steatosis on imaging, whether it be ultrasound, CT, MRI, what have you, the next step in this algorithm is to determine whether or not that patient has cardiometabolic criteria. And these criteria are these 5 items listed here on the right-hand side of the screen. And as you can see, there's a lot of overlap between these and what are essentially the diagnostic criteria for the metabolic syndrome. So we're looking at increased BMI, or increased waist circumference, glucose intolerance or frank type 2 diabetes, hypertension, hypertriglyceridemia, dyslipidemia. If the patient has any one of these 5 criteria, in addition to steatosis, and there's not an alternate explanation for it, such as a genetic disease or excess alcohol, then that patient by definition falls into this category of MASLD. And as you can see from this list, and just knowing the types of patients that you all see on a daily basis, this potentially encompasses a very large percentage of your patient panel. And indeed, this is really what we're seeing worldwide. I mean, this is not just a disease of Western countries and of the United States. This is at epidemic levels worldwide. And prevalence estimates have put this at around 30% prevalence across the world. In North America, we're around 31%, but you can see here that there's a lot of regional variation. And many people would assume that this is a disease of the West, of wealthier countries, but what we see here is that really isn't necessarily true. And some of the explanations for this probably have to do with environmental risk factors, but there are certainly genetic risk factors at play as well. We have several different genetic polymorphisms that we know, SNPs that we know are associated with MASLD and specifically MASH. And I think that helps explain why we see greater rates of this in certain ethnic groups, even here within the United States. Now, these rates are high, but unfortunately, they're projected to continue increasing. Over the past 20 to 30 years, you can see that the global prevalence of MASLD has been rising. In this study, they estimated that in a more current era, that global prevalence rates of MASLD are potentially as high as 38%. But certainly, regardless of which study you look at, these are incredibly high numbers. Certainly, a third of the patients we're seeing, if not more. Now, I talked about MASH earlier and this sort of subset of patients with MASLD who have more significant inflammation of their liver. And MASH is, by definition, a more concerning form that we as hepatologists really focus on, because not only do they have underlying MASLD, fatty liver, but they also have inflammation associated with it that's inherent in the name, steatohepatitis. And with chronic inflammation, these individuals can go on to develop significant hepatic fibrosis, eventually cirrhosis, potentially need liver transplantation. potentially develop liver cancer. So when we look at global prevalence rates of MASH or NASH, you can see here that these numbers are not quite as high as what we see with MASLD, but they're still significant. Here in North America, we're seeing prevalence rates, MASH, of around 5%. And this is not 5% of our MASLD patients. This is 5% of all individuals. So although this 5% numerator is relatively small, when you're dealing with such a large denominator of the population of our country, what this is equating to is, upwards of 15 million people with MASH. Now, these folks, as you can imagine, have a number of risk factors that may predict the presence of MASH. And if we really want to know, if I've seen 20 patients in clinic today, and I know that one of them, statistically speaking, has MASH, how can I try to tease out who that patient might be? Who do I really need to be aggressive about screening? What we know is that diabetes is a really significant risk factor for the presence of not only MASLD, but also MASH. In this study, they looked at prevalence rates of MASLD in type 2 diabetics worldwide. And you can see that here in North America, we're looking at a 68% prevalence rate, so practically a double of what we described earlier. And again, this trend is sort of maintained worldwide, and you can see this trend is on an upward trajectory. So, if we fast forward, and this is a paper that just got published in one of the JAMA journals last month, what you can see is that without effective therapies, what we are looking at over the next 20 to 30 years is increasing rates of MASLD worldwide, increasing rates of MASH worldwide. And the longer that these individuals have MASH or MASLD, the more fibrosis we expect to see, the more cirrhosis we expect to see, the more liver cancers and potentially need for liver transplant we expect to see. This is also just not a disease that's limited to adults that are middle-aged or older. What you can see in this graph up here in box B is that we are seeing patients that have MASLD and MASH in our pediatric populations. When I talk to my colleagues at the Children's Hospital here, they will tell me that they have MASH fibrotic patients that are teenagers, and they even have cirrhotic patients that are teenagers and in their 20s. And here at our transplant center, we are seeing this as well. So this is really a global epidemic that needs aggressive intervention on all of our parts. So I alluded to this earlier, but when we think about what are the patient populations that are at the greatest risk, it really clusters around metabolic dysfunction and the components of the metabolic syndrome. And I oftentimes refer to MASLD as basically the liver's manifestation of the metabolic syndrome. You can see here that prevalence rates of MASLD in patients who are obese, with a BMI of greater than 30, depending on the study you look at, have rates upwards of 50 to as high as 90%. More than half of diabetics have MASLD. When you look at hypertension, again, it's about 50%. And cardiovascular disease, the majority of them have MASLD. So these patients are highly enriched with metabolic disease and dysfunction. And again, this sort of reinforces the metabolic nature of the disease, with obesity being the strongest association, followed shortly after by type 2 diabetes. And when we look at these risk factors, what we know is that the more of these risk factors you have, the greater the risk is. This here is an older study, but they looked at patients at that time who had NAFLD and type 2 diabetes versus NAFLD alone. And what they saw was that the patients who had NAFLD and diabetes had an increased risk of developing cirrhosis. They had a greatly increased risk of liver-related mortality. It's a relative risk of almost 23-fold. And they had a higher all-cause mortality as well. And, this reinforces the fact that, when we have these patients in clinic, although I'm a hepatologist and I obviously focus on their liver ailments, I really harp on the fact that we need to address their whole body. We need to address their dyslipidemia, their hypertension, their sugars, because the number one killer of patients with MASLD is not liver disease, it's cardiovascular disease. It's heart attack, stroke, it's non-hepatic malignancy, hepatic failure, and hepatic tumors do represent a significant chunk of mortality in these patients, but it's by no means, the vast majority. It's a relatively small percent. But these risk factors, the more that you add together, the greater the risk becomes. And so in this more recent study, you can see here that if you have patients with one, risk factor from the metabolic syndrome versus two, versus three, versus more, their survival is greatly impacted. And this likely has to do with, again, their overall metabolic health, but also the risk that, greater degrees of liver disease and liver dysfunction are associated with this. This more recent study that was published in Gastroenterology about 5 years ago really highlighted this, and more specifically highlighted the fact that the degree of liver fibrosis is very much predictive of what the outcome is in these patients. We've known for a long time that how much fibrosis the patient with chronic liver disease has correlates with outcomes. And I think that that sort of intuitively makes sense. If you have a patient who is cirrhotic, they likely have greater risk of mortality and liver failure than does somebody with only mild liver fibrosis. But what this study showed was that there really is an inflection point around stage 2 fibrosis, where the risk of liver-related mortality really begins to climb. And also the risk of all-cause mortality starts to climb as well. And so the degree of hepatic fibrosis, we feel, is predictive of this risk of major adverse liver outcomes, or MASLD, as well as mortality in patients with MASLD. These patients who have more advanced fibrosis or even cirrhosis have a significant increased risk of not just all-cause mortality, but specifically liver-related mortality. And we are actively seeing this in our transplant program and in transplant programs nationwide. 10 years ago, the #1 reason for liver transplant in America was hepatitis C. That has been supplanted by alcohol-related liver disease, in large part because of this rise in alcohol use in general, but also in excellent treatments that we now have to cure hepatitis C. But what we're seeing is that MASH and MASLD-related liver disease is really quick on the heels of alcohol. It's currently the #2 reason for liver transplant in this country. In women, it is the #1 reason for transplant. And when we look at hepatocellular carcinoma, which is, something that makes up roughly 25 to 30% of all transplants done in the US, MASH-related cirrhosis is the most common cause of HCC-related cirrhosis. And it's sort of taken over just in the past few years. So hopefully at this point, I've sort of convinced you of this epidemic of steatotic liver disease and metabolic dysfunction-associated liver disease that we're seeing. And the question then becomes, well, if I am seeing these patients in clinic on a daily basis, and we all are seeing these patients in clinic on a daily basis, how do I try to identify the patients at greatest risk? And specifically, if I have identified those patients, like my diabetic patients, like my folks who have metabolic syndrome, how can I try to risk stratify that patient and decide how much risk they're at for having NASH, but also specifically what we sometimes refer to as at-risk MASH, or MASH with fibrosis. So as hepatologists, I can't do a liver talk without including a biopsy slide. So this is your obligate liver biopsy slide. But what I'm showing here are the different degrees of hepatic fibrosis. So when we refer to liver fibrosis, we oftentimes refer to it in stages. And I sometimes hesitate to refer to stages because I think patients can get confused when they hear stage 2, stage 3. They think of cancer staging when they think of this. But to me, when I talk to patients about this, it's mild, moderate, advanced, and cirrhotic. And what you can see in this slide is that all of these images here show varying degrees of steatosis, or fat inflammation, fat infiltration, which are these globules of lipid that you can see. But in this first bar of stage 1, there's fairly mild fibrosis that's really just occurring in these regions here, but it's not really extending across the liver parenchyma to any significant degree. But as you get more and more fibrosis, you can see there's further branching of this kind of bluish-green fibrous tissue until such point that you have a cirrhotic liver, which is nodular and has dense bands of fibrous tissue surrounding hepatic parenchyma. Now, when we diagnose this, historically, we diagnosed MASH based on liver biopsies. And specifically, we would look at the NAFLD activity score, or NAS score, as a means to identify the presence of MASH on biopsy and to essentially stage its severity. The NAS activity score, the NAS score, or NAFLD activity score, essentially encompasses 3 things, which are the degree of steatosis in the liver, the degree of inflammation in the liver, and the degree of hepatocellular ballooning and degeneration, or dysfunction within the hepatocytes. And what we now refer to as the so-called at-risk MASH are individuals who have an NAS score of 4 or greater, who have at least stage 2 fibrosis or moderate fibrosis or more. But as you can see, we have a lot of patients that we're seeing on a daily basis who are potentially at risk having MASH and who we may want to stage or further assess. And it's not practical to order liver biopsies on all of these patients. We're limited in the number of resources we have available. Obviously, this is a more invasive procedure. There's added cost and risk associated with it. Many patients are not willing to undergo. So clinically, what we often do is we try to identify who we think will be at the greatest risk of having MASH, particularly MASH with fibrosis. And the things that we look at clinically are what are their metabolic risk factors and how many of them do they have? So things we talked about earlier, are they obese? Do they have diabetes? Do they have dyslipidemia? Do they have increased waist circumference? How much alcohol use do they have? These are some of the clinical factors that help us to predict how much steatohepatitis or fibrosis a patient may have. Family history has a role because, again, there is a genetic component to some of this. And in families who have a strong history of advanced liver disease, cirrhosis, liver cancer, need for transplantation, that patient with MASH in front of me who has that history, I'm automatically a bit more concerned about because I feel that they likely have a more risky phenotype, if you will. And then, of course, we're looking for physical exam findings. We're looking for increased waist circumference. We may look for stigmata, cutaneous stigmata of cirrhosis. We may look for other features that you can find with metabolic syndrome. And then we can use various tools to help risk stratify that patient. And what we refer to these as is non-invasive tests, or NITs, as opposed to the more invasive things like liver biopsy. And these NITs can help us to predict who are the patients who are at relatively low risk of having fibrosis versus these patients who have what we term as at-risk MASH. So one such test that's very easy to calculate, widely available, is something called the FIB4. And I'm sure many of you are already familiar with FIB4. What this is it's a score that encompasses age, AST, ALT, and platelets. Easy to calculate. You almost always have tests you need available to you to calculate it in real time. And if you go to Google and just type in FIB4, this is the first hit that comes up. The calculator, you can put in the values and it will spit out a score. And the FIB4 is not great at identifying the specific degree of fibrosis. That's really not what it's for. What it is good at, though, is ruling out people who have advanced fibrosis or cirrhosis. So if you calculate a FIB4 on a patient that has a very low score, below this cutoff of 1.3, that patient has a relatively high negative predictive value for advanced fibrosis, meaning you can, with high degree of certainty, rule out that they have advanced fibrosis. You can't tell if they're F0 or F1 or 2, but you have a high likelihood of being able to say that they're not an F3 or a cirrhotic patient. And on the flip side, if they have a high FIB4 greater than this 2.67 upper limit cutoff, that individual has a high probability of having advanced fibrosis or cirrhosis. Unfortunately, the FIB4 fails in the middle, and there's many patients that fall into this indeterminate range. But again, as I mentioned, this test is really not trying to tell us the specific stage of the patient. It's really being used on the front line, if you will, to try to identify these patients who are potentially at risk of having MASH with fibrosis. If you identify a patient who potentially is at risk, maybe they do not fall below this lower limit, but they're in the indeterminate range, you may then seek to go on to do additional staging. And there's different imaging-based techniques that we can then do. Transient elastography is a commonly used modality. Oftentimes, this is referred to as FibroScan based on the device that's on the market. And this is a study that can be done quickly in the office. You get real-time results. It's non-invasive, it's fast, it's easy. There are downsides, and it's an expensive device up front to purchase. And there is some inter-observer variability to be aware of when one person is doing the study versus another. And there are some limitations in terms of body habitus, how thick the abdominal wall is. It can impact on the validity of the results. But this is a good modality that can be used, again, to help risk stratify patients. We also have ultrasound-based elastography. which gives you many of the same attributes as transient elastography. It also gives you an ultrasound, which is helpful. But again, there's costs associated with acquisition of the device, and it's a bit more time consuming. There's a whole host of other tests that are available that I'm not going to go into for this talk because you could spend an afternoon talking about these. But there are serum-based tests, including the enhanced liver fibrosis test or ELF test. There are other imaging-based modalities like MR elastography. And then there are some newer sort of investigational tests which combine these modalities, which combine transient elastography with serum values or with patient demographic variables like the presence of diabetes or BMI above certain thresholds, et cetera. All of these at the end of the day are being used to try to come up with some sort of construct for how can we best assess risk. And this is a little bit of a busy slide, but it is a useful one to go through because we need some sort of framework for how a PCP or an internist, a family med doc who's seeing a patient in clinic can go about screening. And what this practice guideline put forth, and this was a guideline that was published in about a dozen journals in various societies, all in the summer of 2023. So internal med, endocrine society guidelines, our liver society journals, and then our GI journals all published the same paper with the same guidance. So hopefully this is familiar to many of you. But what this guideline recommends as far as NIT or non-invasive testing, staging tests, is that in a primary care setting, if you have an individual who is potentially at risk, so as I said earlier, the patient who has steatosis on imaging, a diabetic patient you're seeing in clinic, clearly has increased risk. The first line assessment that you want to do is a FIB-4 test. And if you have a FIB-4 that falls below this threshold, you're done at the moment. You should reassess them every few years to see if their FIB-4 is elevated. Of course, we want to focus on cardiovascular, cardiometabolic risk reduction, so lifestyle modification, weight loss, diet, exercise, minimizing alcohol, etc. But for the patient who may have an indeterminate FIB-4 or more elevated FIB-4 score, these are patients who then need some form of secondary risk assessment. And that secondary risk can be VCTE, which is transient elastography, or it can be another test like ELF test, MR elastography, whatever you are familiar with, comfortable with, and have available at your center. And again, if your transient elastography value is low, then these patients can be plugged into a surveillance protocol that their primary care physician can do. But for a patient who has more intermediate risk or high risk, what the guidelines suggest is that these patients be referred on to specialty care, so gastroenterology or hepatology, such that we can do potentially additional risk stratification, consider the role of liver biopsy in those patients, and determine what sort of interventions are needed, whether it's just lifestyle, dietary, et cetera, or whether they may be a candidate for more liver-directed therapy, which we're going to talk about. So most of our patients that you are seeing in clinic who have MASLD will not have significant fibrosis. And through this algorithm, the hope is that you will find lots of patients who are low risk that can be maintained in your clinic, that you can continue to see and assess risk every few years, but who will not need hepatologist services. But why this is so important, again, is that there's such a large number of patients out there who have this, and it's critical that we really work to identify the 20 to 25% of people, who have at least stage 2 fibrosis or greater, and specifically the number of patients out there who may already have advanced fibrosis or potentially cirrhosis, because these are people who are at the greatest risk of developing, of needing liver-directed therapy and potentially developing liver cancer, cirrhosis, a need for transplantation, et cetera. So how do we go about, now that we've identified these patients, how do we go about intervening on them, right? How do we go about working on lifestyle management, lifestyle modification, and potentially some of this liver-directed therapy that I referred to? So the treatment of these patients is multimodal, and there's lots of different things that we can offer and that we should offer. The foundation of everything is lifestyle modification, which we're going to talk about in the next slide. But specifically, we also really want to target their metabolic risk factors. We want to target their diabetes. We want to target their hypertension, their dyslipidemia. We want to, in patients who do have obesity or could benefit from weight loss, we want to actively target that as well through different means, whether it be pharmacologic, endoscopic, potentially surgical means for weight loss. And then finally, there are some newer MASH specific or therapies that are available, or liver specific therapies that we'll talk about at the end here. And there are many more of these modalities or therapies that are coming in years. Now, so when it comes to lifestyle modification, this is a busy slide, but what I want to draw your attention to is that when we talk about lifestyle modification in these patients with MASLD, it really falls on several, basic tenets. We're talking about weight loss, and specifically weight loss goals of at least 5%, which is associated with reduction of steatosis, but hopefully 10% or greater, which is really associated with reduced risk of liver fibrosis. We should think about incretin-based weight loss drugs. We should think about bariatric procedures in certain patients who may qualify for them. But we at minimum want to work on 3 to 5% weight reduction, because that will lead to hopefully improvements in the amount of inflammation in the liver and the amount of steatosis within the liver. Another basic tenet of lifestyle modification is dietary modification. Nutrition science is a hard thing to study, but what we do have some data for is the suggestion that the Mediterranean diet is probably one of the better diets that can be utilized in patients who have MASLD. What I usually tell my patients is whatever diet you can stick with is probably the best one for you. But if you can adhere to a Mediterranean diet, it probably has the best data for you. But the low-hanging fruit are to reduce simple carbohydrates and sugars that are all around us, to try to reduce some of the processed foods and highly processed things that we all consume. We really want to work on increased physical activity, and our guidelines suggest at least 150 minutes of moderate intensity activity per week. So 150 minutes of sweating per week. That's really the minimum goal. And then, of course, there's other basic lifestyle things. So minimizing or eliminating alcohol use, eliminating tobacco use. And then a lot of these things can be done through a multidisciplinary approach and through the help of other specialists, so dietitian, nutritionists, obesity medicine specialists, gastroenterologists, endocrinologists. There's a role for behavioral health and behavioral therapy in many of these patients. When we talk about cardiometabolic risk factor management, we're really talking about these three big things. So dyslipidemia, where there's a heavy role for statins, and I would highly encourage the use of statins in these patients. I know sometimes there can be hesitation to use a statin in a patient with abnormal liver enzymes, but we will be much better served by putting these patients on statin than we will not be. There are many more patients who will die of cardiovascular disease related to dyslipidemia than will patients die of liver injury related to statins. So we should really push hard on the statins in these patients if they need it. Addressing their diabetes with the various regimens that are available to us nowadays. And then finally, targeting their obesity, again, through different means. I talked a little bit about weight loss and its role in treatment earlier, but as you can see here, the pinnacle of this pyramid is at least 10% weight loss, because that's really what seems to predict the likelihood of fibrosis progression. And obviously, this is not going to fit every single patient. If you have someone with fairly significant obesity, maybe a body weight of 300 pounds or more, 10% is probably not going to be enough for that individual. But if we can shoot for 10% weight loss in most of our patients, we will likely see improvements in MASH, in the liver enzymes, and hopefully in their degree of hepatic fibrosis. But this takes time. This takes years to see. We have data for this in the bariatric community. We have robust data that shows that with bariatric surgery and with significant amounts of weight loss, you will have dramatic resolution of NASH. And it really corresponds directly to the degree of weight loss. And we even have data that shows that liver fibrosis can reverse over years of time when patients have this significant degree of weight loss. And so, we used to say that once you were cirrhotic, you were always cirrhotic, and we really don't believe that that's true anymore if we can intervene early enough. We've seen this in the bariatric literature. And now we are even starting to see this in literature associated with GLP-1 agents and with newer pharmacologic agents that have become available for treatment of MASH. So one such agent is called resmetirom, which was approved in March of last year. And this is a drug that has been on the market for almost a year, but was approved by the FDA for treatment of MASH in patients with moderate to advanced fibrosis, or stage 2 to 3 fibrosis, in conjunction with diet and exercise. This is a new class of drug. It's an agonist of the thyroid hormone receptor beta unit, which is primarily present in liver tissue only. And in patients who are treated with this, it results in decreased steatosis, inflammation, and fibrosis. So the study that led to this drug's approval was the Maestro-NASH study, and this was published in the New England Journal last year. And what they found was that in patients who were treated for 1 year with resmetirom, there was a statistically significant improvement and statistically significant development of NASH resolution without worsening of fibrosis in this percentage of patients who were treated. And there was also improvement in underlying fibrosis without worsening of their NAFLD activity score, or NAS score, in a statistically significant number of patients. And this is after 1 year treatment. Incidentally, there were also improvements in dyslipidemia in patients that were treated with resmetirom. This study is actually still ongoing, and we expect to have data in about a year or two for longer term use in this drug. Once we start patients on this drug, there's different parameters that we will look at to determine whether they're responding, and we can look at their liver enzymes, we can look at their transient elastography to see if their steatosis is improving, whether their liver fibrosis is improving. And what we find can help to inform whether we should continue this drug, whether we should stop treatment and look for alternate options, or whether we should reevaluate our strategy and look for alternate options. But this longer term study, we hope, will show that these early histologic outcomes will portend excellent clinical outcomes down the line. That if we are seeing improvements in NASH, MASH within 1 year of treatment, and we're seeing decreases in the amount of hepatic fibrosis within 1 year of treatment, that hopefully with time and additional treatment, we will see decreased risk of cirrhosis, decreased risk of liver cancer, decreased incidence of this MALO, or major adverse liver outcomes. That's what we hope to see in the longer term study. This is a very busy space, as you can imagine, for the pharmaceutical industry, and this is just a small number of the agents that are being investigated for MASH specifically. Resmetirom is at the moment the only drug that is approved by the FDA for treatment of MASH with fibrosis. They do have a cirrhotic trial that is ongoing, that's in phase 3. Semaglutide is in phase 3, and they actually just released their data a couple of weeks ago showing a favorable response. And that company is going to be submitting to the FDA for approval for semaglutide specifically for MASH. I don't expect that this year, maybe next year, but that is coming. There are a number of GLP-1 agents that are in various stages of 1, 2, and 3 clinical trials. Within the family of FGF agonists, which is a new class, we have efruxifermin, which actually just released data last week, showing favorable long-term data in cirrhotic patients with MASH, showing reversal of fibrosis. I expect they will apply to the FDA probably in the next year or so as well. And then we have a number of other phase 2 and 3 trials that are ongoing, specifically looking at this patient population. So there's a lot to come. At the moment, we have 1 agent specifically approved for this indication. By next year, we'll have 2, most likely. By 2027, we may have a handful. And so really what our job in the liver community is going to be in the next few years is figuring out what combinations of agents is going to work. Can we use anti-fibrotic agents along with weight loss agents, along with inflammatory agents combined to really target the various mechanisms by which MASH and fibrosis are developed. So in summary, what I sort of want to leave you with is the fact that this prevalence of MASLD and MASH is already significant, but it's continuing to grow. And it really falls on all of us to really try to identify these patients that we are all seeing every day in clinic. If you see 20 patients a day, you're seeing a MASH patient every day in clinic. So using NITs to try and help identify and risk stratify these patients is critical, such that we can really target the cardiometabolic risk factors that are driving their metabolic dysfunction, so that we can hopefully prevent worse liver outcomes down the road, prevent liver fibrosis and cirrhosis and cancer down the road. There are a number of liver-directed therapies that are coming, and we have some available now. And so, again, identifying these patients such that they can be referred to appropriate specialists for treatment is important. But ultimately, the management of these patients requires all of this. It requires primary care, requires specialists. There's a role, as I said earlier, for behavioral health, for nutrition specialists, to really be involved in the management of these patients. I've always said these patients are perfect for primary care, because primary care is really almost at the nexus of all of these things. But we really need metabologists, if you will, to manage this growing group of patients. So that is what I have. So I'm happy to take any questions that you may have, and feel free to email me if you do have any. But I'll stop here.
Well, thank you so much. I think this is a riveting topic because, as you said, pretty much anybody who's seeing patients is definitely seeing some form or some level of NASH in those patients at least once a day. So we have a couple of questions in the chat and a couple of questions from the audience. One of the things that I think we wanted a little bit clarification on was statins versus triglyceride-specific lowering medications. Is there a use case for triglyceride-lowering medications still, or should we really be thinking about statin in the overall lifestyle management piece?
I think it's probably all of the above is the short answer to that. In terms of specifically triglyceride-lowering agents, I don't know if we have robust data on that with MASH specifically. But I think that, those agents can certainly help if they're targeting one of these components of metabolic syndrome. I really highlighted statins here because I think they act a bit more broadly. And in the liver space, we have a lot of data on the role of statins in various ways in patients with chronic liver disease. There's some emerging data on the role that statins can play even in cirrhotic patients, to help with portal hypertension, to reduce the risk of bacterial translocation in some of these patients. And so I think that statins may be a broader weapon to use, if you will, but I think all the above are probably useful.
Perfect. Thanks. And I think...
Sorry, Justin, can you stop sharing for a minute so we can have
Yes, of course.
Thanks.
Thanks. And I think the other related topic, a lot of times we are seeing supplements and other non-pharmacotherapies being used for treating or attempting to decrease the damage related to MASH. One of them is vitamin E, which has been popularized. What are your thoughts on vitamin E use in MASH?
Yeah, that's a great question. And I meant to mention this in my talk, but I think I breezed over it. So, there was a trial that was published in the New England Journal some years ago that looked at things like vitamin E, that looked at pioglitazone for treatment of steatotic hepatitis. And these drugs are a bit controversial. I think pioglitazone had an issue in that the results weren't particularly robust, and that drug has other side effects, including weight gain, which is really problematic for these patients, who many of which already have obesity that they're struggling with. Vitamin E, there was some concern that was raised about potentially the risk of prostate cancer in men who were treated with high-dose vitamin E for a long period of time. So I think that I still see it used, but it's certainly not approved for that indication. I think the data for it is relatively weak, and there's questions about risk. So I don't advocate for it per se. I don't start any patients on it. If I have someone who really wants to take it, again, I suppose I'm sort of lukewarm on it, but I don't want them to feel that is really the best treatment for their MASH, when there are so many other things that we can target, and when we do have approved therapies for this.
Mm-hmm.
I'll invite questions from Dr. McGinn or Dr. Greenswag while I still court other questions from the audience.
I guess first of all, thanks again. Great overview. I think what really comes out of me is that these folks are floating through our medical practices, and the question is, how do we better identify them? And I think that's sort of a challenge to all of us to think that through. And I have to say, I'm glad you dropped the stigma type fatty liver. I don't know if you did it, but the societies did it. But I also feel like the terminology is still somewhat confusing between,
Yeah.
what if we have MASLD and then MASH, and I mean, it sort of gets a little bit, I wish we could just simplify that a little bit. It seems to me it's like, hey, you have liver disease related to, fatty changes, and then you have basically inflammation and cirrhosis that occur. And it's, I just wish we could come up with an easier way to talk about it.
Yeah.
These phrases get a little confusing, not that you do it. What is the feeling of, because, how do you say it? Resmetirom? What is the medication?
Resmetirom, yeah.
Yeah. It just feels like GLP-1 is going to be sort of the solution for a lot of these, issues that are basically obesity related.
Right.
And, how much quicker should we be, giving, obesity medications to this effect as we move from sort of this mindset that obesity is a chronic illness like hypertension and we need to be treating it, appropriately. How do you think about that in your space? Let's just, I mean, I know we're going to be studying this, but my guess is we're going to show this is highly impactful on this disease.
Yeah, and we are starting to see that. So semaglutide, they released their data oral presentation at our big liver meeting a couple months ago, that showed that they did meet their primary endpoint, which were the same endpoints for the resmetirom trial. So NASH resolution and regression of fibrosis. And so I think it stands to reason that with other GLP-1s, especially some of the more potent GLP-1s that are in combo, GLP, GIP, glucagon receptor antagonists, et cetera, I think we probably will see similar results as time comes. And those drugs certainly have the additive benefit of weight loss, whereas resmetirom is a weight neutral drug and it does not have that. But what we know from that trial is that, there were patients that were given resmetirom as well as GLP-1s, and they still had better benefit than just received one or the other. So there seems to be an additive effect that's beneficial to patients. So, that's sort of where I was alluding to at the end there, that I think that, in the next couple of years, part of the job of our field, if you will, is to really figure out what sort of sequencing needs to happen and what sort of combinations of therapies needs to happen to have the best possible outcome. There may be some patients that really need more weight loss, directed therapies, and there may be some patients that, obesity is not their issue, but they have underlying inflammatory, issues that are present, and they really need a more anti-inflammatory drug.
So
versus,
you put resmetirom in the anti-inflammatory category? Is that more in that?
Has some, yeah, well, yes, in that it reduces, the steatosis burden within the liver, which ultimately reduces inflammation. Yeah. But some of these other drugs, we're seeing benefits in terms of, they're being studied in cirrhotics, and they're reducing fibrosis in cirrhotic patients. And many times our MASH cirrhotics don't even have a whole lot of inflammation present anymore. So I think that all of these different drugs have different mechanisms of action. They target different manifestations of this disease. So there may be certain patients that we use certain combinations for. And that's kind of what we're going to need to determine.
I know Gary's itching to get a question in, so I can talk for an hour, but go ahead, Gary.
I do have one. It's sort of a cluster of questions, and it certainly seems that people have diabetes, you worry about their renal function and so on and so forth, but for the most part, it feels like liver disease is sort of off the chart, out of mind. And so I do think there's an opportunity there. And one question is, you can customize your CMP and add a FIB4 to all those patients. And should we be doing that? So that's one. And two, what patient education materials, what message should we have for the public and for the food manufacturers about what they're feeding us to eat? And because I really do think that here we are in the United States eating highly processed foods of all kinds, high fructose and so forth, that that's all part of this.
Yeah.
So any thoughts about all that?
Yeah, I think on the last part, I don't want to get on the soapbox too much, but I totally agree with you. I think that the environment that we're all surrounded with on a daily basis is a large contributor to this. I sometimes joke with my patients, if you see a food commercial on TV, you should avoid that food because it's being advertised to you for a reason. there's no commercials for broccoli on TV. So, you know, I think we're inundated with this messaging for terrible things, you know, that don't benefit us in any way. In terms of, you know, maybe how to, I think you were talking a little bit about how to, you know, put out more patient education, and I think that's really important, because even now, you know, I see a lot of patients who will talk about this, and they'll say, oh yeah, you know, I've got a fatty liver, I've known it for years, or you know, fatty liver runs in my family, right? Or, you know, things along those lines. And I think it's important for, you know, patients to know that fatty liver, you know, is not a normal thing, right? We shouldn't minimize this and say, oh, it's, you know, it's just there, right? Or, I mean, it independently increases the risk of all of these different things we've talked about. It increases the risk of liver cancer, of non-liver cancer, of liver disease and fibrosis. And so, and it's also highly linked to cardiovascular disease and all these other things. So I don't think we should discount it. And I think that we should really sort of elevate it in the minds of patients to say that, well, if you care about your diabetes and you care about your blood pressure, we really should target this too, because these are all feeding together. You know, it's all part of the same sort of, you know, these are all interlocking circles, if you will.
I mean, I think I'm going to double down on the GLP-1s, because I think that we can talk about the food industry. We can talk about a lot of issues. I've seen a bunch of chats in here. It's a chronic medication. You got to take it for life. It's too expensive. Bottom line is, the data is getting very, like, almost absurd in terms of the data proving the benefits, whether it's sleep apnea, cardiovascular disease, liver disease. And all of the medications we use to treat those diseases are chronic. The end organ damage from all of those are very expensive. And the price is going to drop as we get more indications for this. It's really going to be, you know, it's sooner than we think. This is going to be the primary drug that we're going to be treating obesity as a chronic illness with. And the price point's going to drop. And it'll have dramatic impacts on things like liver disease, as you're talking about. But anyway, I don't think it's going to take that long. The data is getting so persuasive here. But I'll stop. Ankita, do you want to close us out?
Yeah, I think it sounds like we need a round 2 of this discussion, specifically thinking about GLP-1 and other meds.
Very exciting.
Because the chat has been active. We've got lots of questions remaining. So first of all, thank you for just a great intro and a start to the dialogue. One of the things I'm taking away is really thinking about how do we make it easier for our primary care teams to identify patients who may need a diagnostic algorithm, and then fast track them to treatment or to referral. So more to come on that for sure. And it is definitely an ongoing dialogue. So sounds like we will have a round 2. And thank you.